portfolio. Through these comprehensive strategies, strengthen the pain product portfolio. Through these comprehensive strategies, thank you all for coming together and joining us today. And I'm looking forward to a productive and an insightful discussion that will happen. Same time, I'm also privileged to have our chairman and speaker, Dr. Khalid, as well as Dr. Bart. Both of you, welcome to Riyadh. You're already from Riyadh, and Bart, welcome to Riyadh. Also take the privilege to welcome our Haleon team. We have first to start with, this is our agenda here. And we have Andre Bekish, he's our general manager leading from front. And we have Anthony here. Anthony is as the expert global manager for Panadol. We have Mariam from the Middle East Africa team handling the marketing for Panadol. We have Wissam, who is a local expert market manager for the pain category. And we have Basim, who is the digital lead for Saudi Arabia. So they will take you through the presentation for the next 1 hour and 40 minutes. And now let me invite Anthony to take through the first session. But before I hand over the session to you, I have a question for you. What is the inspiration behind Haleon Pain Management Index?
Sure. So I've got a few slides around what is the inspiration behind. Hari, if you could pass the clicker. Yeah. The clicker. Thank you. On what the inspiration is for the Haleon Pain Management Institute. So for us, Haleon as a company, our vision is providing healthcare with humanity. We today reach close to 2 billion patients, consumers, almost every year. Our endeavor is to reach another 1 billion more patients, and that would come when we start reaching patients and consumers in markets like Saudi Arabia, where there is a huge penetration opportunity for us. And pain therefore becomes very, very central to us achieving that mission of reaching 1 billion more consumers. Now pain, almost each of you would have experienced pain at some point or the other, and I'm sure some of you would have experienced pain in the last 1 week. This is some data about pain being a widespread global phenomenon. 93% of the population suffer with pain, and almost 1 in 3 of us have had pain in the last 1 week. But when you look at pain, there is of course a big gap that, while pain is so prevalent, despite that close to 60% of patients wait for days or weeks before they treat pain. And Saudi Arabia is not very different from the other parts of the world. Close to 63% of them wait really to treat pain, and some of them don't treat pain at all. Now we do this study called as the Haleon Pain Management Index. This is a study where we look at the perception and the behavior and the motivations behind patients when they treat their pain. And what we find is 59% of people living in pain suffer with deep isolation, deep feelings of social isolation, and 41% of them feel misunderstood. Now, and we know that close to 40% of consumers seek HCP's support when they want to treat their pain. Now, as per the same Haleon Pain Index, we find that 53% of pharmacists and 60% of doctors, patients want these pharmacists and doctors to take their pain more seriously. So they feel that they need to be more involved, more supportive, so that these patients feel understood and they take their pain more seriously and therefore better manage pain. And with that, at Haleon we believe for us to create that impact, we believe that every pain matters, every outcome can be improved, but it cannot be done alone. It needs to be done together, because no one, no patient, no consumer, none of us should tackle pain alone. And that led us to launching the Helion Pain Management Institute. And the Helion Pain Management Institute, and Mariam will take us through the details, but the Pain Management Institute has 3 pillars on which we want to advance our science. We want to advance our science, we want to make sure that patients understand their pain better by providing them the right level of knowledge. At the same time, we think there is an opportunity to enhance skill as well as education of HCPs so that they can better support their patients in managing pain. So without too much, let me ask Mariam to take us through the 3 pillars which will be central to the Helion Pain Management Institute. Over to you, Mariam.
Thank you so much, Anthony. And actually, as Anthony have said, we have 3 main HPMI pillars, starting with the first one, which is the patient knowledge, which is really essential for the better pain management as it helps to increase the patient's quality of life and reduces the burden on the HCPs. So actually, listed here are some initiatives which help the patient knowledge to be increased, like the Helion Pain Index, the patient tutorials and stories, patient advocacy groups and resources, and finally the Community Pain Management Hub. Moving to the next pillar, which is the science and research, and actually it's a very crucial one in the pain management as it provides evidence-based treatments, and it's actually supported by different aspects like the multidisciplinary faculty, the webinars, the advisory board, publications, and the innovations as well. And finally, moving to the third pillar, which is the education and skills, empowering our HCPs with resources and tools for better outcomes. And this will happen through the condition education modules, the practical toolkits and resources that we are supplying, the partnerships with the institutions and the different academies, and finally, the soft skill learning modules. Sorry for that. And to summarize the HPMI, it will help our HCPs to be your patient's go-to pain expert. And now I'm handing over to Wissam so that he can share with us the HPMI faculty foundations.
Thank you, Mariam. Assalamu alaikum. Hello, everyone, ladies and gentlemen. Yes, as Helion, we are committed to bringing our pain faculty environments, and our goal to support the environment. Key knowledge and expertise are actively shared. So I will take you through our pain faculty. This is our pain faculty. The most important thing, as you see, we have the different backgrounds of the speakers is essential for a holistic understanding of pain. So as you see, our Helion Pain Management or faculty, it contains different cultures, different speakers, internationally key pain experts, and also the gender balance and fair representation is very important and essential for development of for most effective and secure everything. And today we are happy and very excited. We have one of our faculty member, which is Dr. Bart Morlion, our speaker for today presentation. Thank you. Over to you, the Basim will take you to the next.
Thank you, Wissam. Thank you, everyone. As you see, I think everyone is excited about what is next. And what we are always do, we are always on, because Helion Pain Management Institute is not only it's just a launch, and it's the beginning of the excitement journey toward pain management. Our objectives is always to support healthcare professionals to provide the right content for their practice. So So maybe you are wondering about how we can actually find the information. So we are having our Helion Health Partner Hub. So everyone is eligible to have an access on that, and they will find a content related to Helion Health Partner and or content related to Helion Pain Management Institute. And that would be really helpful. And the good news that we already started, and whoever now having access to Helion Health Partner, they will have eligibility to download some materials related to Helion Pain and Management Institute. And we always, I would say, like we updating this content through an efficient communications with healthcare professionals. Right now, as you can see here, all resources that you can see in Helion Pain and Helion Health Partner is actually structured in a way that is matching the three pillars, which is patient knowledge and support, science and research, education and skills. As you can see from the beginning, patient knowledge and support, we are actually providing some materials like allow you to listen to the pain stories for the patients and how the patient actually affected by the pain and how they are actually describe the pain in a way that is actually matching their, their emotional stuff. And also what is coming, patient tutorials on top 5 gaps in understanding pain management as well. So when we move to the second pillar, which is science and research, we are actually every year in September gather with all the global expert speakers, and we are describing or launching or even discussing different type of topics. These topics is related to pain. I will give you some examples that how we are actually see the pain in future. Also, what is the rule and guideline in the pain, how we actually addressing the social impact of pain as well. And like we are doing it in a way, or we are delivering through the Global Pain Awareness Week, which is normally done in September as well. So, and the third pillar, which is education and skills. So when you go to the Helion Health Partner, you will see like a lot of toolkits that is available and it benefits your practice as well. This pain protocol on 9 most common pain states, patient case studies, pain modules, and pain and age tools and resources. But on the top of this, we are very soon going to launch a Patient Connect program, which is, we are planning to launch it in a way that really entertainment and very engaging to healthcare professionals. And also, this is actually an example of how you are actually going to find the content. So when you go to the Helion Health Partner, or if you have access to Helion Health Partner, you will see that Helion Pain Management Institute, and you will navigate through this one and you will find the content that matching our 3 pillars that we discussed previously. So what is the exciting right now? I want to announce in February 4th, 11th, 18th, and 25th, we are actually having a small scale of pain webinars that is going to launch online as well. And in each table, you will see that paper in front of you with a QR code. Every one of you can scan, registered, and these materials will be also accredited. And day 1, day 2, and also day 3 and day 4, which is going to be in 25th of February. So welcome everyone to our new launch of the Pain Management Institute. And right now, it's a pleasure to welcome Prof. Khalid Al-Dosari. He's a head of endocrinology and diabetes in Dalla Hospital. Dr. Khalid, welcome.
Thank you very much. It's a pleasure to be with you today, and I'd like to thank all of Helion Group. And I saw a harmony in this team and wonderful team that work in this even for, I think, more than 1 month. So thanks for them, and it's a pleasure to be with all of you tonight. When you talk about chronic pain, it's as Dr. Anthony just mentioned. I think all of you have some sort of even acute or chronic pain. And the numbers is scaring. So in Saudi, we have 46% of patients having some sort of chronic pain. And if you look to the community, the prevalence of chronic pain is 4%, which is a little bit huge if you compare it to other countries. And I do believe that we have a gap in knowledge of us as a physicians, also in treating patients. So I'm a diabetologist. I'm dealing with patients with chronic pain like DPN, diabetes peripheral neuropathy, every day. And I can tell you that I fail sometimes to give a right treatment. So not most of them, or not all of them are effective. So 25 to 30% if you give X treatment, then you will move to other treatment. Most of our patients like to have an easy and simple medications, like paracetamol and others, or local treatment or so. And I have a question for all of you. And by the way, I'd like to thank the who watch us in the webinar. I think we reached more than 2,000, is it right? 2,200 or 2,300, which is a good number. Do you think who is suffering from chronic pain? Male or females most? Male? Female? Yes, yes. So, younger or elderly patient? Younger or elderly, geriatric population? Geriatric, yes, that's right. So what do you think the most common site of pain in our community? Back pain, excellent, excellent. So we are suffering. And I'd like to invite you. We have a research group in Prince Attam University, and we published 6 or 7 papers regarding chronic pain. We are shocked that the chronic pain is linked to a lot of like psychological distress, pre-diabetes and diabetes, pre-hypertension and hypertension, even for chronic neck pain. So chronic pain is something should be treated, should be addressed, and should be not missed in your patient. So without any further delay, we are very happy and proud to see Professor Bart from Belgium, which is the country that I loved, and I invite all of you to visit Belgium. So he's a professor at University of Leuven. He's, I think, the president of the Pain Federation, I think, in Belgium. And he'll talk about the dealing with chronic pain. And he is an anesthesiologist and pain medicine. And I have a belief that the best people who talk about the pain is anesthesiologists and pain specialists. So welcome, Dr. Bart, and it's a pleasure to be with you today.
Thank you very much indeed. Thank you very much indeed for the kind invitation to come to Saudi Arabia. It's my first visit to this amazing country, and I want to welcome you also from my side. I want to thank Helion, and I want especially, now I'm looking into the camera, also welcome all the people. How many? 2,300 people watching us tonight. And within the next 40 minutes, and I will put my watch so that we will finish on time, I will deal with the topic we're discussing today. It's about understanding and accepting pain at every stage of life. Before starting, I want to disclaim that I do have numerous interactions with pharmaceutical companies, both for my clinical research at my department, but also in advocacy, in consultancy, and in speaking activities. I have brought 6 talking points with you. My old teacher told me never talk about 7 or more topics. So that's the reason 6 topics. Understanding chronic pain, pain across ages. Then I want to give you some impressions on the impact of pain the assessment in different stages of life, and then, of course, some treatment approaches. And I want to finish with some future outlooks. Let's kick off with understanding chronic pain. But before dealing with this topic, I want to tell you a little story, if you allow me. It will take 2-3 minutes, so I will deduct it from the 40 minutes. You shouldn't be afraid that I will overtake my time. I want to start with a story about 2 nails. This is the first nail. It happened in UK. A construction worker fell down. This was the result. It's a 15 centimeter long nail pierced his foot, his shoe. He was brought into an emergency room, screaming for pain. And immediately this well-trained nurse asked him for a pain score. Who uses pain scores in his daily practice? Numeric rating scales, for instance, from 0 to 10. Anyone? So, yes. 0, no pain. 10, the most worst pain you can imagine. This guy said 11. Okay? So he was crying, and the colleagues had to put him asleep to do the diagnostic and to remove the shoe. And to make a very long story short, the nail went exactly in between 2 toes and didn't leave any scratch. Okay? So there was no tissue injury at all. The second story about the nail, and both are published, comes from the United States. Here a guy was working with a nail pistol, and he bent over and by accident, so this device was failing, shot himself a nail through his open mouth up until his prefrontal cortex, which is in a very important area also for pain. The only thing was, he had his headphones on. He had good music on. It was 5 to 5, he could go drive home. Only on the 6th day, he went to his dentist because he had a bad sleep because of dental pain. And the dentist found this nail. So what I want to bring, the message here is that we always should acknowledge the biopsychosocial nature of pain. Pain is by definition a biopsychosocial phenomenon. And the man's agonizing pain in the first instance was only elicited by false perception, and in the second case, this guy attributed his pain to something he knew before, which was dental pain, because he experienced in his life also dental pain. That brings me then to the definition. Never talk about pain before getting back to the definition, because the definition of pain tells us it's an unpleasant sensory and emotional experience. In my waiting room, I do not see patients who find pain pleasant. Maybe my colleagues in other departments do, but I not. And so, in the definition, it's also stated you do not need to prove tissue damage to talk about pain. And that's so true for chronic pain, because in many situations of chronic pain, especially post-traumatic pain, post-operative pain, pain after healing, you will not find any more active tissue damage. Acute pain clearly has a protective function. That's clear. It should tell us, be careful, do something, and prevent further damage. However, chronic pain is something completely different. It's beyond the healing time. And by definition, it's pain, ongoing pain, recurring pain over 3 months. When we go to the prevalence, and we heard it already, I heard already a very nice summary from the chairman of my talk, so excellent. And it's by repeating that it will stick. It has a very high prevalence. International studies have shown 1 in 5 people suffer from chronic pain. In some countries, 1 in 4. Everyone knows, works, or cares for people in chronic pain. And it's really something which goes hand in hand with a lot of comorbidities, like, for instance, diabetes, like, for instance, cardiovascular diseases, metabolic syndrome, many other things. It's a little bit too late now to dwell into the details of pathophysiology of chronic pain, so let me summarize it. If we look at the transition from acute to chronic pain, there are a few processes which come into place, and you can wrap it up as maladaptive plasticity, neuroplasticity. 3 points: sensitization, meaning that there is amplification of synaptic strength; neuroinflammation. Many processes in pain have to do with neuroinflammation, and that's the reason that some strategies decreasing inflammation are very helpful. But also in chronic pain, for instance, if we go to lifestyle, nutritional adaptations with more anti-inflammatory ingredients, also anti-inflammatory vitamins and trace elements can be helpful in the management of pain. And then loss of inhibition. Loss of inhibition means that our own brain system, which is able to reduce pain, is failing. That's what happens in chronic pain, a failing system. So remember, chronic pain is more about sensitivity than about tissue damage. And that's the reason that early intervention for the prevention of this transition from acute to chronic pain is so important. And early means also self-care, taking care at a very early stage of your pain. Acute pain, preventing chronic pain. And then, second point I want to discuss, if we want to deal with treatment and management approaches, it's so important to have a good mechanistic view on pain. And there are 3 mechanisms to remember. Actually, officially, we only have 3 mechanisms. The first one you all know, because you mostly see on a daily basis patients with nociceptive pain. It's normal pain, it's activation of nociceptors, and mostly you will find tissue damage. Most acute pains like postoperative pain, trauma, injury has to do with nociceptive pain. Also, many forms of musculoskeletal pain are actually nociceptive pain. So if you cut yourself with a knife in the kitchen, this is nociceptive pain. The good point is that your nervous system actually is working normally. It is doing what it should do. That's the main difference with the next one, neuropathic pain. In neuropathic pain, there is some damage, there is some disease within the somatosensory system, and this can lead to very special pain, burning pain, tingling pain, electric shocks, and examples are given like painful diabetic polyneuropathy, like pain after shingles, like radiculopathy, sciatica, but also many forms of postoperative pain. And nowadays we know that many forms of chronic low back pain, neck pain, also establish to some point neuropathic pain components. No, the system is not working anymore in a normal way. The nervous system is damaged. And that the third form, that's a point of discussion. There are still many countries where they do not accept that there is this form of pain. It's nowadays we call it nociplastic pain. And what's happening with nociplastic pain is that your complete pain system is oversensitive. It's hypersensitive. And mostly it relates to pain in several places in your body. Chronic widespread pain, fibromyalgia is a very nice example of this nociplastic pain. But remember, there are also many forms of low back pain, neck pain, headache, which also fit into this definition of nociplastic pain. That means pain without identifiable nerve or tissue damage. So it's no nociceptive, no neuropathic, but there is pain. And this pain is real. This is not a psychogenic pain. Every pain is psychogenic because it happens in your brain. ICD, WHO and ICD have clearly stated and given also a new terminology, chronic primary pain. The main features are emotional distress and loss of function. Functional disability. And the examples I gave you already. So, after this introduction, let's have a look at the different pains which occur in different life stages. And here you see from baby until the elderly, and there are some very common pain states which occur in every single age. MSK, musculoskeletal pain, muscle pain, dental pain is something which happens throughout all life stages. But of course, growing pain is more a feature of young children. Certain forms of rheumatological juvenile arthrotic disease is more typical, of course, for juveniles. If we look at differences, gender differences, dysmenorrhea is in the age in women of the reproductive age. And then when patients get older and older, then these arthrotic problems arise, more and more MSK, also low back pain increases. The only good point with elderly people is there's only one type of pain which slightly decreases. You know which one? Headache. Headache is something which decreases, all the rest increases. If we look at children, children can have traumatic acute pain, abdominal pain, dental pain. These are typical things which happen in children. But they also in children, you can witness chronic pain states. Abdominal pain, pelvic pain, muscle joint pain, CRPS, complex regional pain syndrome, also in young people. And then, of course, all kinds of post-injury and post-operative pains. And then if we move from the children, adolescents towards the adults, you will see that there are more and more comorbidities kicking in. And that you will witness also more and more work-related pain syndromes. And the musculoskeletal pain keeps on increasing. Also neuropathic pain increases when people get older. Never forget that also dental pain is ongoing, and this is a typical point where people also have this need to do this self-care. And then this brings me to the highest challenge in pain management. In most countries of the world we see, or in many countries in the world, we see a turn of the age pyramid. In my country, this is disturbed completely. Our new generation will not be able to pay my pension anymore in a few years. So, and the burden of pain is also enormous. We know that elderly living at home, and these numbers, there is huge variability depending on the methodology, but you see 25 to 50% of the elderly living at home experience pain. If you go to home care, hospitals, then you will see that this goes up to 80%. If you do prevalence studies in these institutionalized patients, up to 80% patients suffer from pain. And of course, then you can ask, okay, but pain is a sensory modality, as I stated in the beginning. And we know that sensory modalities decrease while aging. Many of you, including myself, we need reading glasses. We need hearing aids when we get older. Presbyopia, presbyacusis. So the question is, do we have something like presbyalgos? Do we lose the capacity to register pain in our brain when we get older? Many research has been done, and yes, the number of fibers in the nociceptive system goes down. And yes, pain thresholds go up. Does that mean that elderly patients experience less pain? No, because at the same time, our descending inhibition is also failing. And that means that you have a reduced efficacy of the endogenous inhibitory system and that the pain tolerance differs. So this goes down. The net effect is mostly that elderly patients, at least, if not more, experience pain than the adults. As heard and learned already during the introductions, pain prevalence increases with age, and many studies have shown this. And we also even need gender-tailored approaches in elderly people. We know that and there are many cultural differences also, depending on the regions in the world. Men stick to the more stoic positions. They do not like to talk about their pain. Also in therapies, we know that it's much easier for women to engage in mind-body techniques, like yoga, like Tai Chi, like certain mindfulness exercises. Men do not like this. They do not like to engage in this type of therapy, although it's very useful. It's part of the game. Maybe you are not aware of this, but social isolation, which goes hand in hand with elderly age, decreases pain thresholds. So elderly people not having visits of their children, not living in a social network anymore, their pain thresholds decrease. And very recent research even has shown that loneliness itself creates physical pain. What is the impact? I know every speaker likes to use an iceberg. So the tip of the iceberg is a referral, for instance. Please, pain specialist, take care of my patient. Problem with pain, I cannot manage it. But if you look under this iceberg, you will notice that most patients will have mood disorders, will have anxiety, will have depression, will have catastrophizing ideas, will have stiffness, will have kinesiophobia, fear for movement. They will have also loss of independence and the weight differences, weight gain, weight loss. So you notice that pain itself brings in a typical comorbidity. And that means that also in the assessment and in the management, we should take care of this comorbidity. If we only address pain as an isolated factor, we will not manage the job. So, a little check if you're all still awake. Please have a good look at the screen. And I hope this will work also for all the people online. Is everybody seeing now a set of parallel lines? Okay? Yeah? Excellent. Is someone seeing circles? Okay, great. So I do not have to be worried. Yeah. What are you seeing now? And maybe you can show it, what you notice now. Okay, yes, indeed. Yeah. Parabolic and then concave, convex. These are the same lines. The only thing I changed is the environment, is the context. Pain for pain, it's the same. Depending on the life situation, depending on the circumstances of an injury, of a situation, depending on the context, you will get completely different pain experiences in between patients, but also within the same patients. And that's an explanation also why pain scores are why there is such a high variability in reported pain scores. Okay? Because pain is an emotion. And if we look at modern functional imaging of the brain, like fMRI, like PET scanning, then we notice what we knew already and which is in the definition of pain, that if you look at all the sites within your brain, all the networks in your brain related to emotions on one side and related to pain on the other side, you will notice that actually there is a huge overlap and you cannot dissect it. So by definition, pain is an emotional experience. And there is a shared neurobiology. Brain networks, neuroinflammation, genes, hormones, they fit in emotional situations and painful situations. And that brings also the role of stress. Every form of stress, especially chronic stress, will influence your pain thresholds. Relational stress, stress at home, stress with your children, with your parents, with your partner, during your job, with your boss, with your colleagues, financial issues. All these things lead to stress, and stress reduces thresholds for pain. And we heard it already. I didn't mention it explicitly, but indeed, women suffer more from chronic pain than men. If you do not believe me, have a look in my waiting room, in my clinic. Almost 70%, 68% to be exact, of all our patients, and we have over 13,000 patients, are women. And it's because of these brain networks where the balance between resilience and vulnerability is actually defining the pain thresholds. And this is disbalanced more swiftly in women than in men. My wife would say, you men lack emotional quotient to be disbalanced. That's her explanation to this finding. So pain sensation leads to catastrophizing, leads to stress, leads to unpleasantness, to suffering, and this is a vicious circle and keeps on going. It leads to anger, frustration, anger also to the medical community. Why does this therapy doesn't do its job like it should be? And that brings me then how to assess this pain problem. If we look across ages, your assessment method should be adapted to the age category. I told you already about the numeric rating scale from 0 to 10. In most European clinics, it's a duty. We need to do this, and we need to document every day at least 2 times within the chart of a patient who is hospitalized the pain score. Otherwise, we will lose our accreditation. The pain score is one thing. It's the gold standard for pain assessment remains the self-report. You can do this in different ways, but it should be adapted to the cognitive abilities. Of course, if there is a crying newborn, you cannot go and say, hello, how is your pain score today? If you have a patient with Alzheimer's disease, you cannot ask, give me a pain score. So you need special assessment tools. In children less than 4 years, actually only observation is useful. There are some exceptions, there is some variability. Between 4 and 6 years, it's more a combination of, first of all, the classic numeric rating scale. Surely from the age of 8 years, you can use the NRS in children already, so very easy. What do we use if you need to use an observation scale? Sorry, I'm a little bit too fast now. You can remember it by the acronym FLAC. Face, legs, activity, cry, and constability. Because a baby, if it's in pain, it will retract, will make fists, it will cry, it will grimace. No giving, feeding will not consolidate. So these are the signs that a baby can be in pain. And there are many different validated instruments which you can use, and many of these are, or most of them, are also validated in your language. So you can always find this. If we look, for instance, another tool can be an adapted NRS, an adapted VAS. It's the facious pain scale, where a child can point, I feel like this. And for the adults, we use NRS. We can use a verbal rating scale, mild pain, moderate pain, severe pain. We can use a VAS, visual analog scale. It's a ruler, 10-centimeter ruler, where you just indicate how much pain you have, but you do not show a number to your patient. So many different assessment tools available. In specialized settings, we use what is so-called the multidimensional pain assessment tools, which means that we are not only looking for the pain intensity. When somebody's sitting in my waiting room as a new patient, I know that he or she, mostly she, will report a high pain score. Otherwise, she wouldn't be there. So what I want to know is, how is this affecting your daily life? How is this affecting your job? How is this affecting your sleep, your physical ability to look for yourself, your interrelationship with your partner? How is this going? And that's what we do also in validated instruments, like, for instance, this is not comprehensive, it's not a full list, but mostly use the brief pain, the BPI, brief pain inventory, and the McGill pain score. These are instruments. But you cannot do this during a normal clinic. It takes time, and it's more for a specialist setting. In the elderly, we come back to the FLAC in some way, because in elderly with cognitive impairment, we look at the facial expressions, we hear the vocalizing, the cry, and we look also at the postures. And often these are misinterpreted as agitation, and patients then get sedatives, and then they get unsteadiness, and they fall and get a hip fracture. So often hip fractures are induced by not registering and assessing pain in the correct way. Remember that also in patients with mild cognitive impairment, so dementia in the first stages, one of the problems with these patients is that, and I hope you will see this again, that there is not a black button on my ticker, so that you can use a thermometer. So it's like a VAS, you turn it around, and in the vertical way, even patients with cognitive mild impairment are able to make an abstraction and indicate how much pain they have. How to treat this? I like to discuss with every new patient our treatment strategies. And then on a paper, we always sign, and all my fellows and all my residents, they're obliged to make a little drawing, not to use a photo, no, to make a little drawing together with the patients. And it's a Greek, we call it the Greek temple, with 3 pillars. The middle pillar is what we call the medical technical intervention, and that's mainly the use of painkillers, pharmacotherapy. But there can be also other interventions, like, for instance, interventional pain management. That's what a lot of anesthesiologists also do, neurosurgeons do, orthopedic surgeons do, interventional pain management. But it's also about application of heat, of cold, physical therapies, which have also their place in self-care. Then, movement and exercise, physical activity, and then taking care also of the psychosocial dimension of pain. Mind-body techniques, train the brain concepts. Movement and exercise, physical activity, for many chronic pain problems, this is key. MSK pain, you need to treat also with physical activity, promote physical activity. Every single chronic pain should be stimulated to increase the level of physical activity, because independently about the indication to start physiotherapy, increasing physical activity will activate within your brains the descending inhibition, will be able to enforce your descending inhibition. And it has been shown to have many other health advantages, of course, on medical, on weight, on many different aspects, also on well-being, depression. Actually, some recent research has shown that physical activity can be as powerful, if not even more powerful, than the use of certain antidepressants. On the other hand, medical technical, we have these non-opioid analgesics like paracetamol, like the NSAIDs, like ibuprofen, like diclofenac. We have the opioids, but there are many issues with opioids, and actually we're very strict on opioids. It's mainly reserved in cancer-related pain, in acute severe pain, postoperative pain, traumatic pain, and in very well-selected chronic pain patients where all other means do not work. There is no indication to use opioids in nociplastic pain. Please do not prescribe opioids in your patients with fibromyalgia. It has really negative effects. And then the atypical ones. Atypical, it's a term I like to use because they do not fit in these other categories, like the antidepressants, like anticonvulsants, but it fits more into the management of, for instance, neuropathic pain. And some of them have proven efficacy also in nociplastic pain. Importantly, I do not like to copy-paste the WHO stepladder, which is classically copy-paste in every textbook for every type of pain, because you have to take into account also the mechanisms. And it's of no use to use opioids in nociplastic pain, and it's of no use to use, for instance, paracetamol if you have 100% neuropathic pain. If you have a mixed pain, it can be useful. So you have to look also at the mechanisms. And there, OTCs are important, because OTCs improve accessibility, especially in those regions, in rural areas, in patients who are also have financial issues. It's easier, access is much easier, there is more convenience. Patients can reduce the need for doctor visits. In some countries of the world, it's really an issue. They cannot pay a doctor visit. Still, they are in pain, and their self-care with OTC is important. It's mostly easy to use. We need to take into account that you need a certain level of education and understanding, so public awareness should be raised. And that's one of the parts of the HPMI campaign, and where also this awareness and education is so important. And in the end, we want to improve outcome. We want to decrease health disparities because of the availability of certain forms of medical care. And you have to ask for a risk factor assessment across age groups, especially in the elderly. I will not go into every detail, but mostly it's important to know about the concomitant drugs, about polypharmacy, about comorbidity. These are, and then never forget, often there are also psychological issues, and this should be also addressed. Which brings me to these psychological issues. I mentioned it already, mind-body techniques, not very popular in the male population. They do not like to engage in yoga exercises and mindfulness exercises. It's much easier to convince women to engage in these techniques, although they have proven efficacy. It has been shown that it works. It even works better if you enhance them by social networks, if you do this in a group with other people. And we know that, for instance, music is one of the techniques which also can work. Listening to your favorite music can be pain-reducing, can enhance the medication you are taking on an OTC level. Playing music even is better. You know what is best? Singing in a choir, together, the social dimension, singing in a choir is one of the most powerful mind-body techniques you can engage in. So if you go for the practical self-care, OTC medication is a pillar, physical therapies and exercise, and remember, also cold and heat. And part of them are available as patches, as gels, as creams. Yeah? And although we are an academic center, a tertiary referral center, most of my patients have been in at least 2 other pain clinics. Nevertheless, suddenly we engage with also topical therapies because nobody in Belgium engages in topical therapy as a doctor. They say, oh, that's something for people at home, and I do not believe in topical therapy in pain. And some patients are on normal OTC medication with the help also of topical treatments. And lifestyle modification. I do not have the time to discuss with you the advantages of healthy lifestyle, but healthy lifestyle includes also, apart from this movement, also nutrition. And nutrition, it's clear, anti-inflammatory nutrition helps also and is helpful in not only acute but especially in chronic pain. What can we expect? I had to make a selection because there are so many interesting projects going on, and actually it's really accelerating. It accelerated, especially in my eyes. In my view, one of the accelerators was the pandemic. The pandemic, which led to, in many healthcare systems, to the installing video clinics, telephone clinics, the promotion of apps, of wearables to get information in a time where we could not meet so easily our patients. And it sticks. It really sticks. Nowadays, almost 40% of all our encounters are remote with our patients, which was almost zero before the pandemic. Because for the simple reason it was not recognized, it was not even allowed by the ethical commission of the hospital. Now telemedicine is exploring, and especially AI, which will give the possibility, if we feed AI with so many millions of data coming out anonymized from these electronic charge, we can learn this. And to give you one example, for instance, it's perfectly possible to feed AI with the faces of people, to learn them when they are in pain, and to even give a pain score. So this is what we can expect in the near future. Myself, I'm involved with one of the microchip companies, academic companies, it's not a commercial company, in wearables and with little cameras on pain. And that brings me to my second last slide. What are my personal guiding principles in my daily job? Because I'm a clinical professor, that means I do not only teach and give lectures. On 3.5 days a week, I see patients. So I run 7 clinics over the week. And first is do not harm. Do not engage in therapies where you already have a complex situation with a lot of psychosocial issues where you can harm your patient. Immediate, fast, swift therapy is necessary. In my case, this is before I see the patients. Yeah? Mostly I see when it's too late. But we should be able, especially also as a pain specialist, it's my duty to help also every single initiative where we empower patients to take care of their acute pain and to give the best therapy in a holistic way of chronic pain. And therefore it's so important to stimulate self-management. And in self-management, I like the KISS principle. Not like kissing, but more like keep it simple. If we can address issues like warmth, massage, stretch, relaxation, yeah? Why should we engage in very McKinsey therapies, which are expensive, where you need devices? First thing can be done at home. Second one, you need to go to a specialist setting, which is far more expensive. So I'm not on a good relation with my management, especially not with my financial director, because I mostly engage in very cheap therapies, which can be continued at home and do not pull the patient into an academic hospital for very fancy techniques where you only have the chance to gain 1-2% success rate. And remember, there are no simple solutions for complex problems, and there are no quick fixes for chronic problems. That means that we need a stepwise approach. My final takeaway, so remember, chronic pain is not just a symptom, it's a life stage specific challenge that requires tailored, empathetic, mechanism-driven care for better outcomes in our patients. I thank you very much indeed for your attention here in the room and the thousands behind our screen. Thank you very much indeed.
Professor, for the nice and excellent talk, as usual. So, since I'm the chairman, I'll take the privilege to ask you before the audience. So, it's a theoretical question about pain threshold. Is there anything that we can improve or make our pain threshold high? And is it familial? Is it something different between others, between patient and patient? Pain threshold.
Pain threshold, yeah, thank you. Yeah, very excellent question. Pain thresholds can differ from patient to patient, yes indeed.
Yeah.
But will also, in myself and in yourself, differ from stage to stage in your life.
Yeah.
And even on a day, you have differences in pain thresholds. It's partly related, it starts with an endocrinologist. The cortisol levels,
Yeah.
which have a diurnal pattern, already change your pain thresholds.
Thank you. Just for the audience, it's 5 minutes. I ask you just to stay. We'll finish now within just 5 minutes. So any question? Any question from the audience? Yeah, go ahead.
Do we have a mic?
Yeah.
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 Well, I'm Haitham Najjar, pediatrician from Riyadh. Well, first, thank you so much for this noble and precious presentation. Of course, touching every individual in his lifetime, whether a doctor or a nurse or teacher or whatever. So, of course, it's a very important subject. For me as a pediatrician, you know, one of the major issues we do every day across the globe is giving vaccination for kids. And you mentioned that really this is subject by itself is not addressed very carefully. So some practices they do as routinely to give painkiller, some they don't. Just I would like to have your recent view for this.
Yeah, thank you.
Thank you.
It was on one of my slides, but I agree I didn't mention it explicitly. Vaccination is really an issue, and we know that it starts with the heel prick after birth. We know that even the heel prick and the first vaccination can influence the status of your nociceptive system for the rest of your life. And therefore, for every single situation, of course, there are some parents who say, oh no, my girl, my boy needs to be strong, so just give him the... No, it has been shown that in a comforting way, like in very newborns, like glucose can do the job. In the younger children, we use busy bees, which give cold and some vibration, and then give the stick. So yes, we need also some preventive measure in just doing vaccination. But I know if there are 400 children waiting in a row, then of course it goes very... But if we do have the time, use the methods which are well validated.
Thank you very much. Just for the sake of time, just you want to close up?
Yes, before you close, so my name is Andrzej, I'm general manager of this Halion company which organized this event. I wanted to express massive thank you, Professor Bart and Professor Khalid. I think that you never in your life presented at 11 at night. So it is probably one of the experience. Thank you very much for coming to Saudi Arabia, for visiting us, and for meeting our amazing GPs and amazing expert team and healthcare professionals in Saudi Arabia. And being here as well on the stage, I just wanted to say thank you very much for all your support for our team and for your amazing work which you are doing. Of course, today we are not talking about brands, but you really help people to improve quality of life. So thank you very much for all your support. And again, Professor Bart and Professor Khalid, thank you very much. Again.
I think this is the best final and close-up. Is that right? Yeah, go
Thank
ahead.
you.
Excellent. Thank you very
so
much.
Thank you.
very
See you,
much.
inshallah, very soon.
Welcome.
Take a picture.
They should.